Welcome to Psychologist Talks. Today is going to be part 4 in a series about borderline personality disorder, and today is going to be all about treatment. Now, disclaimers first. This is important that anything I'm going to be saying in this episode, never mind any episode, it does not constitute medical or treatment advice, especially this episode. All I'm trying to provide is information. It is not meant to replace professional advice. It cannot be applied to your unique situation. That includes if you're a consumer, a provider, or anybody in between. So, as I always hope these are informative, do not take this as constituting medical advice or direction that you should be taking in your treatment. Now, what are we going to talk about when it comes to treatment? First, we're going to actually address medication. It's an interesting area just to kind of be aware of and how I talk to patients I have with BPD about medication. And it's going to actually resemble how I talk to most of my patients about medication. And then we'll go into kind of key factors, and a confusing phrase with episode 1 being key elements, but just what are the key factors of what we're trying to address within treatment? Because there's various modalities out there. I might reference one or two along the way, but I think, they're all successful for a reason, and that's probably because they're addressing a few key elements. Now, my list won't be exhaustive, but the ones I want to address, first one should not be surprising if you listen to or watch any of my stuff, because I'm always talking about framing. Number 2 is how do we apply, or how do we maybe vary the treatment a little bit based on, most specifically, organizational level. So it's going to look or feel a little bit different despite somebody all having the same diagnosis of, BPD. And then we'll go into transference and countertransference. We'll probably end with just some words of encouragement, because if you've been watching all these episodes, there's a heaviness to these conversations. And I can imagine if you have been diagnosed with BPD or have a family member, or maybe you're worried if you could be diagnosed, I can imagine as I'm talking, while I hope there's a lot of empathy and understanding in what I say, it can come across as really heavy and really inaccessible and challenging. I mean, it is challenging, but I don't want it to be demoralizing either. So I'm going to end with some words of encouragement, both for providers and for potential consumers of treatment. So let's jump in. Let's do medication first in brief. The medications typically prescribed, I'm not a medical prescriber here, I didn't go to med school, but what you typically see are antidepressants, antipsychotics, and mood stabilizers. This is an interesting aside. Mood stabilizers are actually anticonvulsants. A little fascinating little fun fact. And we often don't really know 100% why they work and how precisely they're helpful, especially for conditions like bipolar. Never mind the mood instability with borderline personality disorder. A big thing to note, though, is that efficacy of these medications for BPD is very mixed. Now, I don't know if we 100% know why it's so mixed, but if I had to take a guess, well, one, remember, this is a massive collision of nature and nurture. And so if we ever were to do studies prospectively, I really wonder if we really were diligent or had really effective methods to somehow parse out like the percentage, not that there's any, distinct percentage here, but, more genetically loaded cases versus more environmentally trauma loaded cases, if we might start to see some efficacy stats actually come out that are a little bit more clear, where perhaps the environmental loaded ones are a little bit less responsive, the genetically loaded ones maybe are a little bit more responsive. I don't know, hard to say. But also remember, we're not addressing as much of a known biologically linked condition like the really heavy hitters like bipolarity, schizophrenia, and those sorts of things. And medications maybe have a harder time addressing things that are more temperamental or are more kind of diffuse when it comes to the genetic side of things. This is all just, remember, me speculating, so, I don't know for sure, but I do wonder about that, and that being really key and critical to the mixed efficacy. And this is all very important to say, because when you say that there's a mixed efficacy, it could be really demoralizing or even just demotivating to go seek out any medication-related treatment when you're hearing, well, it might not even work even if I try. Well, this is how I frame it to any client, but especially clients with BPD. One is it never hurts to try. If you haven't tried before, it doesn't hurt to try, because the goal of what medication is doing is trying to soften symptoms, or another way I explain it is like bracketing around the more extreme symptoms. And the treatment for the therapy for borderline personality disorder is very challenging. And to bracket around more extreme symptoms can actually be incredibly helpful. And I think this is one reason why in dialectical behavior therapy, DBT, many providers will require, and it's part of the alleged manual, not everybody follows it, gold standards, will say like medication is a required adjunct. But even within that, they give that caveat. It's to soften. Do not see this as a cure-all, because if you see this as a cure-all, you're going to shoot yourself in the foot. You're just going to create more grief and more frustration, because that's not how this is going to work. But notice as we're talking, we're essentially doing what is a big piece in treatment treatment for BPD, and that is dialectical thought. Even if you don't ascribe to DBT, dialectical behavior therapy, the idea of dialectics is universally helpful, I think, for most people. We're just not good at dialectics in general as human beings, if I have to be frank, that two things can be true at the same time. But, with BPD, it's especially important and especially relevant as we move them through treatment. So notice the dialectic, though, with a medication is like, on the one hand, it's important, right? It could be efficacious and important. Even if we're not expecting full amelioration, it can be beneficial and push you a little bit. And just by virtue of doing that, we're also inclining towards the perception that medication can be helpful. And the placebo effect is real. It's never, it can be complete placebo. But these medications are likely doing something. But when you add the belief, the positive sentiment that I'm exploring a way to soften my symptoms, it can increase the likelihood that there's a positive response. What I also tell folks and caution folks, if they're like, well, I've tried it before, it's like, well, when did you try it? One, were you 10 years younger? Or two, did you only try it for a short period of time when you were under extreme duress? Remember what we just said. If it's softening symptoms and you're under extreme duress, you might not notice the softening because it's a uniquely bad time. But maybe it was more efficacious than you believe, and you can always try it again and see if it has more of a softening effect, or maybe the dosing, right? Time of day you take it, whatever it might be. On the flip side, though, don't put all your eggs in that basket. You are going to do yourself a disservice if you go into this believing it's going to eliminate most of your problems and you're going to forge forward and be done with treatment and be all better in 1 year or something. Could that be true? Maybe. But let us not overextend. And so two things can be true. It can be efficacious, but it's not going to be everything. It's not all black. It's not all white. And that's a big thing with BPD. Now, do note, I give choice. I personally... I do not push these. If the severity is really high, I will encourage more strongly, but it's not like a contingency for me where you must be on medication, because I'm a big believer in consumer choice, especially when the efficacy is already mixed. But again, I will help and aid in the conceptualization process about medication. So there you go. So let's shift over to the kind of key factors stuff, starting with framing. So framing is a big one for me. To me, it is essential in pretty much any type of therapy we do, the only exceptions being very short-term, singular problem-focused. Like perhaps in those, you don't need to burn some time framing, but if you're doing any iteration of the longer-term work, it benefits you to frame the type of work that you're doing so that you have a common language and a generally common set of expectations. And most importantly, a common language around we are allowed to talk transparently with one another. That's super big for me. I'm a big transparency, big kind of direct communication type of guy. And I want clients to feel comfortable with that when they're coming to see me. Well, you do the same thing with borderline personality disorder, but there's kind of two primary factors that you're priming. Well, before we get to the two, let me note, as a quick reminder, I'm making 3 symbol here if you're watching the video, but remember also, you're not always going to know someone has a personality disorder, and this is why it's important to frame proactively. So it's like the worst case scenario, you have a general frame, and you can kind of harden around, well, not harden, but you kind of reinforce that frame if you're like, oh, maybe there's a personality issue, especially BPD going on. So, just keep that in mind. You're not always going to know. But let's say you do know. There's 2 primary things that really I elevate and emphasize extra if I know BPD is there. One is going to be one that we're going to talk about in further detail in a second, and that's managing around risk. And, different language for that is treatment interfering behaviors. The notorious ones being risk-related, suicidal gestures, self-harm, and those sorts of things. And, the initial framing that I'm offering is essentially that is going to be our priority number one, no matter what. The minute that is present, we are going to have to focus on it, because if you are preoccupied with death, we are not getting you into a phase of healthier living. We cannot play that two at the same time. We have to move you away from death-related, risk-related content to be able to get to anything else that's going on in your life. Now, a client might say, oh, that's never happened to me, or it's been years. It doesn't matter. Frame it anyway. It needs to be framed. Or if you're a consumer watching this, kudos to you if it's been a while, or maybe you've never engaged in any risk-related content, self-harm related content, but it is safer to talk about this proactively than not at all. The worst case scenario here is which is a really good case scenario, is you're moving somebody through risk-related conversations, and those are essential. There's so many people, and there's even a lot of providers in this world that see risk conversations as a little bit too transactional. And so even if the person's been in treatment for a long time, or even if you have been in treatment for a long time, it's good for you as a provider or for your provider to get more familiar with, the experience around death and your relationship with death. Never mind to have more robust, potentially, conversations around safety planning. Safety planning is not just like ifs and thens. It's an element of understanding what propels someone towards death, what propels someone towards self-harm, the steps, the iterations, the coping mechanisms that have been tried or untried, the ones that are reliable versus unreliable. Those are all absolutely essential understandings of people's relationship with risk-related content. Now, let's say that has already been done very efficiently. Okay, so you double up on that. Now you know a little bit better as a provider, and now your provider knows. Well, the next step of this is, I'm just going to go into the whole thing. So we're talking about framing still, but I'm going into the death stuff and the risk stuff. But essentially what you're also doing, if all that other stuff is really fine and dandy, is you're punishing the behavior if there's any element of attention seeking or overt manipulation to it, which can come up. It doesn't always come up, but it can come up for individuals with BPD. And that might sound gross to some people. I mean, you look at the psychology research, motivating people through punishment and fear is not the best way to learn, but it does have its place. And this is one of those times. This is one of those times where it has a place, where it's essentially like, I'm going to make this really miserable for you if you keep doing this. I'm here seriously supporting you through the risk content, but I'm also going to make this miserable if you can't find a way around it. We're not going to get to talk about all the other things that you probably want to talk about more, and that's especially the case for the attention seeking or overt manipulation components. The reason why, again, I'm going to say this with extreme caution. Remember, there's still legitimate risk here. We're talking about a dialectic here of both end. And if it is tinged by attention seeking and or overt manipulation, it is relationship seeking. And so when you're punishing, saying, I'm not going to do any relational emotional content, and I'm only going to focus on the risk content, it inclines them to do something more productive about that risk-related content because they want to get to the emotional relational content. It's so much of what they're preoccupied with. So, again, it might sound dirty, it might sound manipulative as a provider, but it's not intended to be. You don't know the difference between legitimate risk or not. And so you just treat it seriously. And you will incessantly treat it seriously until you can secure a sense of safety. That's the whole point. So I kind of overlap both talking about risk content, which would be, the beginning stages of treatment if it's present, but we're still in framing. So we're still talking about framing. So that's number one in framing, is really getting agreement about, we're going to talk about this. You're acknowledging, right? Like, this is going to be primo. You need to bring this up to me. We're going to talk about it seriously so we can get you out of that phase, so then we can focus on all this really important stuff. Cool, high five. Remember the frame, the point of the frame, so we can point back to it if the frame is violated. If the risk-related content comes up, it's no surprise to them because we talked to them about it and we agreed upon it. We're going to hyper-focus on this till we can get it under control. Number two is conflict. Conflict is inevitable, almost inevitable. Internalizing types maybe a little bit less inevitable with BPD. And so I'm talking about trust and transparency with everybody. But I amplify it a little bit if I know there's a case of BPD in front of me, which is like, I tend to be really direct. And that directness, that willingness to confront and challenge you, it might seem to you like I am being a pain in your butt, or I'm being mean to you, or I'm being overly harsh like other people in your life. But it is very essential for you to hear that this is in the service of caring for you. And we need to figure out a way to navigate that conflict effectively. That we can talk transparently and openly with one another. We can have heated emotions with one another. But at the end of the day, we're keeping logic in place, and that we can always come back and talk about it. Like, ruptures might be inevitable, and we need to be able to commit to coming back together and being curious and learning about that. Now, I am very specific in noting that does not make me the arbiter of right and wrong. I will not always be in the position of authority, and anytime you have an emotion, it's a problem, and anytime I do something, it's not going to be a wrong, I'm infallible. It's not the point, but we're going to negotiate around that. I will make mistakes, you will make mistakes, and we need to be able to come back to the table. Can you agree to that? And you are setting the stage, essentially. Your provider is setting the stage, or you as a provider, you're setting the stage to be like, okay, what do we do when conflict arises? And it prevents flight risks, where they're like, screw this provider, I'm not coming back. It prevents providers, it holds providers accountable to not default into or get stuck in positions of frustration or telling or knowing. It just gives this like open space and encourages transparency and equity, with a condition that tends not to operate terribly well with that. And in doing so, not only are you ensuring that not ensuring, but trying to ensure that the relationship can stay intact so you can continue work, it creates a milieu where you can have a reparative emotional experience with somebody. I say you as in like the person with BPD can have a reparative emotional experience of like, look, we can still exist despite conflict. And that's like huge. That's huge. So you notice I'm kind of transitioning into, what are the key factors of treatment beyond framing? So let's recap. Framing, risk-related content, and managing and navigating conflict are kind of the two that I propel forward. And treatment has to start with that risk-related content because you can't get to anything else. But let's say you get past the risk-related content. What do you do next? Well, the challenge is there's not really a next. It depends on the individual. And this is where I go back to that notion of organizational level, or think of it as like degree of severity. The more severe, the more kind of the lower the organizational level, the more concrete and supportive it tends to be, the more structured and supportive it tends to be. It's more just kind of if-thens. It's more behavioral in nature. And there might be some insights and themes that are rising along the way, but the emphasis is we need to decrease the overt chaos at all costs, because the more chaos you create, the more you will stay stuck. So how do we just interrupt those things at a frank level? It might not be massively healthy yet, but just stopping the chaos from happening. And going into insight with these individuals at these organizational levels can be quite dangerous, because it can provoke a lot of emotional reactions that then leads to, ironically, sadly, more chaos. Going to my change over time episode, basically you're focusing a ton on grounding and just better, healthier action. Not like epiphany, changing the world action. Just get the action to be at least a little bit safer, and that they're grounding a little bit better. The observation component floats in a little bit, but you're not doing too much of that because you're trying to secure risk, 1, 2, general stability. That's it. Now, as people progress, or if people are just more organized in general coming into treatment, whether it's just the state of where they're at, or perhaps a lot of past treatment has been successful, you start to infuse that kind of metacognition stuff and mentalization stuff a little bit more of like, isn't this interesting? Let's not just do diary cards as DBT stuff for the sake of, just tracking, the ABCs, that there's some antecedent that leads to some sort of emotion or some sort of thought that leads to ineffective behavior, and let's replace with healthier behaviors. Let's get some insight into some general themes. Where is this coming from? Why is this coming up? Sort of like transference and using the relationship in the room is, to me, really useful and most fruitful, because now you're not just getting the day-to-day in shape, you're getting them to telescope out. You're getting that observational process, the observing ego, where the hope is they're starting to catch this earlier and they're starting to make links, and that will slowly open the field for doing different actions that are actually quite scary, and in the past would have been so destabilizing that they wouldn't approach, or when they did approach it would sadly lead to destabilization. But here, now that resiliency has been built, and observation, the observing ego is stronger, mentalization's better, metacognition's better. They seem to like notice and catch things and see the dialectics in things. Now, okay, let's get more insight and push those insights into scary new behaviors. And that's so cool when you get to that place, because that's when you don't just see the end of the chaos, you start seeing the growth of something new and promising and exciting for them. And it's just a really fun time to get to. There could be reversals, right? The whole idea of this dimensional understanding of personality is people can move between organizational levels. But that's that sort of like, be prescriptive, be more structured, be transparent throughout all of it, but more structured, more rigid, more just kind of transactional, steer away from too big of insights at the lower organizational level. But as they advance, you can get more into insight and more into brave new territories. Super cool, super fun. So that's kind of the key elements. I know I kind of jumbled it all together, but that's the kind of gist. Getting healthier with oneself, like what's going on emotionally. How do I get just healthier, frank behaviors? How do I then increase those healthy behaviors? How do I actually amend and begin to improve substantially my relationships? And how do I begin learning about myself and expanding myself? That's that kind of ideal trajectory. I will note the time frame for this is years often. It is often years. This is not a quick process. This is universally true with most personality-related issues, and the lower the organizational level you're starting from, the longer it's going to take. And that's totally okay. It's totally okay. What's also really important in this, and very challenging in a healthcare world where providers can often have a lot of turnover, whether it's an agency or pay structure, private insurance methodologies switching and stuff, who accepts what, it's like having a provider for multiple years. Once again, this is universal for a lot of personality disorders, but it feels really essential and really important for borderline personality disorder. That consistency of having a provider who gets to know them for years on end is so, I wouldn't say essential, it's just so beneficial. And the way I often say it is like their personality psychology. Think about it. It's chaos about oneself and chaos about other people. They enter into a therapeutic relationship. It will easily take 6 months to get to workable space just from a relational standpoint. Never mind you, if you're acting as an auxiliary ego, like helping them with these mentalization processes, it takes a while to get to know their trends. Their tendencies, because they will often say one thing, right? Because they're not good at looking inward, and then you'll find quite the opposite is true. Not because they're trying to manipulate. Every once in a while, yes, but they struggle with that. And so even you as a provider will often feel like you're flying blind for a while, as you're like, oh, now I'm seeing the link, and they might not even see that link yet, and I'm like 8 months into treatment. And so you're getting into year 1, year 2, year 3, and now you're really, the rubber meets the road. And if suddenly a provider switch happens, it's not the end of the world. Progress is incremental and it builds on itself. But it does cause some delays, and that sucks. It does. If you're a consumer listening to this, and especially if you experience this, you can attest to this. It sucks. It sucks starting over. It's hard to start over. So in an ideal world, it's long-term, and you have, ideally, the same provider who really gets to know you, assuming that they're being effective and the therapeutic relationship is working. So, transference and countertransference, and then we'll do the kind of words of encouragement, and then we'll be done. Transference and countertransference, it's interesting because in many ways, I don't know how to say this. It doesn't mirror narcissism, but I'll say it this way. It mirrors in the sense that there's valuing and devaluing going on. How the valuing and devaluing manifests is what is different. So let's go to narcissism first. The valuing and devaluing is stark. It really is. You're the best. You're amongst the greatest, or you are amongst the plebes of the world, the inconsequential people, and you will feel it. But there isn't like there isn't like a franticness behind it. It's just like a frank reality that they present it as. It's like, you are good, you say reasonable things, you are smart, I agree with you. Or it is, I don't agree with you, I will make these passive statements that make you feel small and insignificant compared to great old me. Whereas, for borderline personality disorder, there's a franticness, there is a noisy busyness to it. Where if you are valued, there is this like gushing around you of just like, you're so great, you're so wonderful, you're so amazing. It's not like you're amongst the class of the elite. It's just, you're the best thing in the world. You're my favorite person. You're so great. You say all the right things. You're so helpful. And it's just not just, positive here and there. It's just like, ooh, you're the best thing ever. You're pillared. And it's just so much emotion to it. And very similarly, you get to devaluing. It isn't just like, you are small and I will now make you feel small. It is like, you are going to feel my wrath. You will feel extremely uncomfortable. It's the whole notion of walking on eggshells. The thing that I said that, I'm not trying to make them sound violent or anything, is they know how to take out a knife and just stab you right between the ribs and be quite vicious while doing it. Now remember, this is all fear-based. It's just, narcissism has such a stalwart defense. They seem like they are in control when they're valuing or devaluing, whereas with borderline personality disorder, it's so chaotic. They lack control as they value and devalue. And that's kind of the difference when it comes to transference. And so from a countertransference lens, initially you might be quite sympathetic, especially if you're in the valued position. It's like, oh, they like me a lot. That's really cool. Great. But remember, this is why we frame. It doesn't matter if things are like, oh my gosh, you're the best thing ever. You still frame around conflict because you might not be in that valued state forever as a provider. And so, inevitably, you might have some sympathy. But even if you remain in a valued place, you will get to, as a provider, if you're a provider, get to a place of frustration. Because there's the chaos. And the absolute chaos. And when you're trying to hold this thing that just keeps slipping through your hands or feels like it keeps morphing, it can get incredibly frustrating. Never mind when they get hostile with you very frequently. And you will start dreading potentially sessions because you're like, oh my gosh, I don't want to deal with this. I don't have the mental capacity today to go into this, know that I need to challenge, and then face the wrath of challenging them. And that's normal. And if you're a consumer listening to this or a family member listening to this, remember the dialectic here is we're allowed to be frustrated. Just like if you're a consumer, you're allowed to be frustrated at your provider. It doesn't mean that the relationship is over. It just means that it's challenging. It just means there's a lot there. And this is a call to action for providers that, like, you got to be ready to do this work because it is on you to contain better than your patient. It is. But you are also allowed to be frustrated and just sometimes filled with dread. And if we look internally in many ways, that frustration and that dread, while it is challenging to hold and very frustrating for you as a provider, is in a way an insight into their internal world. Remember, so much of borderline personality disorder is about projection and projective identification, where you will feel what they feel, and it will be uncomfortable. And now, again, your job is not to contain the world for them. They are still responsible for their behavior, and you still intervene based on the countertransference at hand. But just, as a moment of kind of telescoping out and empathy, you are both sharing in a parallel process of frustration and uncertainty and joy and all sorts of things. And but again, it's challenging. It can be very challenging. Which leads me, I guess, to the final point. And the final point here is some words of encouragement. I was kind of alluding to that already. If you're a provider or a prospective provider, somebody who's kind of getting into the field or maybe thinking about getting more specialized in personality work, think about what I just said. Be prepared. Know what you're getting into. Personality work is not easy. It is some of the most intensive work that I think you can do in this field because you are holding a lot. You have to hold a lot in personality disorder work. It's a long game issue, especially when folks come in at lower organizational levels. You are doing that auxiliary ego work a ton, and it takes a long time. It might not always feel like you're making many gains. And in fact, especially with conditions like BPD, you will often feel as though you take 2 steps forward and 1 step back, or 2 steps forward and 4 steps back. But at the end of the day, it can also be incredibly rewarding because you're helping people encounter themselves in a more fruitful and a more balanced and a more economical way that allows them to become who they have always been on the inside, but have been obscured by these difficulties and these defenses. And you need to reach out for help too. Have consultings. You can have a consultant, someone else who's doing personality work, or a consulting group. A dialectical behavior therapy. I think will often call for like DBT, support groups, not support groups, but you're consulting with one another because you will lose the forest for the trees. It's the nature of the condition is so much chaos that you get wrapped into the chaos and lose the perspective yourself too. And having outside brains, your own third eye, as you were the third eye for the patient for a while, is important. So you do not lose yourself in the process. Never mind just managing the stress, having a place to go yourself. Just like I'm lost and I'm feeling demoralized in this. Now, if you're a consumer, a patient, a family member listening to this, is like, oh my gosh, I don't want to be a burden. No. Remember, there's almost beauty in what I'm saying. Is your provider is going on a very similar journey with you. It's not the same. They can't know what you're feeling. It is intense work. It is challenging work. It is going to be a challenge for you or your family member. And they will meet that challenge not with like imperviousness, but they will meet you as a fellow human being, and they will help guide you through the chaos that can be quite consuming and quite confusing for you. But you have to be willing to stick with it. And provider choice is an important thing. I mean, if you've never been in treatment, or maybe you have been, be sure you do feel like there's a match with the provider. But my words of encouragement next to, hey, it'll get better if you stick it out, is be sure you stick it out. If you are getting ticked at your therapist every once in a while, double check. I mean, maybe you do need to change providers, but often it will be because you're doing good work. And if they're really well trained and they kind of have this interpersonal kind of chops that are required, regardless of theoretical orientation, to do personality work, you will work through that conflict and find your way to a better place of being, even though periodically you might not like your provider, and every once in a while it might feel like your provider doesn't like you too. But remember the dialectic. It's two people meeting and trying to hold chaos together, and that's going to cause conflict. You're going to get frustrated at each other once in a while, and that's totally okay. As long as you keep working through it, you keep persevering, you'll get somewhere. You will get somewhere. So again, I don't want this to sound like so doom and gloom because of the complications and the layers and these stark words like chaos or emptiness that I've used, or voids. Like, they can feel really heavy. I hope those are validating to say or to hear, these stark words, but it does not mean it is fruitless. It does not mean that it is hopeless. It's just layered, and it requires a commitment. So I think that's it for treatment. Again, it's skimming the surface. We didn't get into a bunch of things. I don't think I even went into a bunch of different interventions like mentalization-based interpersonal therapies, stuff like that. But again, it's meant to be a broad overview, not a session on, how to treat or how you should be treated with borderline personality disorder. But hopefully, yeah, skims the surface, gets folks thinking, gets folks curious, some central themes. Yeah, we'll end there. So without further ado, thanks for listening and watching, and as ever, stay curious.